Welcome to the Rad Onc Smart Review Head and Neck Cancer series.
This is episode 35, Salivary Gland Two Adjuvant RT Triggers and Planning.
Welcome back. So if you were with us for the last session, that was episode 34, you'll know we really spent our time laying the groundwork, the fundamental laws of the salivary gland universe.
Right. We talked about how histology really drives everything.
Exactly. And that surgery is king. It's the primary intervention. And then the adjuvant decisions, what we do after the surgery, are driven entirely by these risk factors that are hiding in the pathology report.
Things like PNI, perineural invasion, and of course margin status. Those are the big ones that keep us up at night.
They really are. And today, the mission is a bit different. This is the bridge. We're taking that case we anchored on last time, our 62-year-old patient, and we're basically moving him from the operating room and turning his path report into a board-safe, totally execution-ready post-operative radiation plan.
This is where the rubber meets the road. It's moving from the what and the why to the how, the practical application.
And let's be really clear about what's at stake here. This is not just clinical practice. This is, incredibly high-yield stuff for oral boards.
Absolutely.
In that exam room, they're going to ask you to justify why you're turning the beam on. What are your port indications?
And you'll have to define your volumes, your CTVs. And you have to defend your dose levels down to the gray.
You can't just wave your hands and say, standard dose. It won't fly. You need the numbers. You need the rationale.
Right. So our goal today is that by the end of this, you should be able to just recite the port indication list, maybe even with some citations in your back pocket. And you should be able to define the anatomic boundaries of a parotid surgical bed from memory and explain exactly when and, just as importantly, how far to track the facial nerve.
Okay, so let's not waste any time. Let's get right back to our case anchor.
Perfect. So just to refresh everyone's memory, this is our 62-year-old man from the last session. He is just back from the OR. The procedure was pretty significant.
It was aggressive.
A total parotidectomy with facial nerve sacrifice and an ipsilateral selective neck dissection.
Okay, so now we have the final pathology report. In a board case, this is the data. These are the facts you can't argue with. You just have to manage them.
Exactly. So let's go through it line by line. First, the histology is salivary duct carcinoma.
Which we should stop right there. That's high grade by definition. It's an aggressive cancer.
It really is. People often compare it to high-grade ductal carcinoma of the breast. It loves to metastasize, and it fails locally very quickly if you let it.
Okay, so high grade. What's next? Tumor size.
3.4 centimeters. And now for the adverse features. Perineural invasion, PNI, is present, and the report even specifies it involves small, named nerve branches.
So not just microscopic PNI, but it's on named structure.
Right, and limbovascular invasion, LVI, is also present.
Wow. Okay, so a lot of red flags already. What about the margins?
This is key. The report says the deep margin is close, and they define it. Tumor is within 1 millimeter of the ink.
Within 1 millimeter. Okay, and the nodes. What did the neck dissection show?
One level 2 lymph node is positive. And not only is it positive, there is extranodal extension, or ENE, measuring 2 millimeters.
So the cancer has broken out of the lymph node capsule?
It has. So picture this. You get the call from the surgeon. They say, this patient needs radiation. What's your plan?
Right.
Before we spell it out, let's make this an interactive moment. I want you, the listener, to pause for a second. Think about it. Identify the specific triggers in this case that are screaming, treat with radiation.
Yeah, take a moment. What are all the reasons? Don't just pick one. List them out in your head.
Okay, ready? Let's see how you did. If you listed high-grade histology, perineural invasion, lymphovascular invasion, a close margin within 1 millimeter, node-positive disease, and extranodal extension.
Then you nailed it.
You absolutely nailed it. This patient is basically the poster child for post-operative radiation. He checks every single box.
He really does. So now we have to build that plan, and we have to be able to present it cleanly.
Yes. Let's start with the 60-second board script. This is how you synthesize all that data into a concise, professional presentation. You can't ramble in the exam room.
You have to sound like a consultant.
Okay, here's how it should sound. I'll do this verbatim. Listen to the structure.
Go for it.
This is a 62-year-old man's status post-total parotidectomy with facial nerve sacrifice and ipsilateral neck dissection for salivary duct carcinoma. Final pathology shows a 3.4 centimeter high-grade tumor with PNI LVSI, a deep margin within 1 millimeter, and one positive level 2 node with 2 millimeters of extranodal extension. Multiple port triggers are present. high-grade histology, PNI, LVSI, close margin, nodal disease, and E&E. I recommend postoperative IMRT using a 3-tier CTV approach. CTV1 covering the broad surgical bed with 1.5 to 2 centimeter expansion. CTV2 for the high-risk bed plus 1 centimeter. And CTV3 is a boost volume for the close margin and E&E regions. Dose will be 66 gray to the boost volume given the less than 1 millimeter margin, and E&E 60 gray to the high-risk bed and involved nodal levels, and 54 gray to elective neck. I will track the facial nerve pathway toward the stylomastoid foramen given the nerve sacrifice in PNI. The key late effect is xerostomia. I will prioritize contralateral parotid and submandibular sparing per Quantec guidelines.
That was perfect. Concise, covers all the key data points, the plan, the volumes, the doses, and even the toxicity management. That is a pass.
It's a formula. So now let's unpack that formula. We need to dig into the core clinical content, starting with that port indication framework.
Okay. There is a golden rule I want everyone to burn into their memory for salivary glands. It really simplifies the first step.
What's the rule?
Postoperative RT is recommended for almost all malignant salivary tumors except for the truly, truly low-risk ones.
And that's a real shift in mindset from some other cancers. And when we say truly low risk, we mean like a unicorn. A very specific combination of good features.
Right. It has to be low-grade, early T-stage, widely negative margins, and 0 adverse features. If you are missing even one piece of that perfect puzzle, you're probably treating.
The best framework to use, both in clinic and for the boards, is probably the ASCO guideline. That's Geiger et al. From JCO in 2021. They give a list of strong recommendations for post-op RT.
Let's go through them. It's important to know the why behind each one.
Okay, first on the list is adenoid cystic carcinoma, or ACC. The guideline says you should offer radiation to all patients with resected ACC.
Even T1N0, that sounds so early. Normally we'd just watch that.
I know, it's counterintuitive. But ACC is just notorious for these little skip lesions and for perineural spread that's completely invisible to the surgeon.
So the recurrence rates with surgery alone are just too high.
Unacceptably high. It burrows along nerves like a subway train. You have to clean it up with radiation.
Okay, that makes sense. Number 2 on the list.
Positive margins. That one's pretty straightforward.
Right. If you leave cancer behind, you have to treat it.
Third is high-grade histology. This includes salivary duct carcinoma, like our patient, high-grade mucoepidermoid carcinoma, and interestingly, it also includes ACC if it has more than a 30% solid component.
Ah, right, because that solid component is a marker of aggressive behavior.
Exactly. It acts more like a high-grade cancer than a typical slow-growing ACC. Okay, number 4 is perineural invasion, PNI.
And we're not just talking about clinical PNI where the patient's face is drooping. We're talking pathologic PNI seen under the microscope.
Yes. Any PNI is a huge risk factor for local recurrence. It's a highway for tumor cells to escape the surgical field.
Okay. Number 5.
Pathologic nodal disease. If it's in the nodes, it's already left the primary site.
Makes sense. 6.
Lymphovascular invasion, or LVI. Again, another sign the tumor has access to the body's highway system.
And finally, number 7.
T3 to T4 disease. Just big, bulky tumors. They are bad actors and need more than just surgery.
That's a really comprehensive list. And if an examiner pushes you for evidence for why we do this at all, what do you cite?
You can mention Terhard's Dutch registry data from 2005. It's older but foundational.
What did that show?
It showed a significant improvement in local control with radiation specifically for patients with these adverse features. T3, T4, PNI, close margins, bone invasion. It really validates this aggressive approach.
Okay, let's drill down on margins for a second. The boards love margins, and there is a huge trap here.
There is.
You hear people say, oh, anything under 5 millimeters is close. And in a lot of cancers, that's kind of true.
But that is a trap in salivary gland radiation. It is not the rule here, and more importantly, it's not how the big cooperative group trials defined risk. We have to look at RTOG 1008.
RTOG 1008 is the key trial. So how do they define close?
They define close as tumor within 1 millimeter. 1, not 5. And that definition is critical because it triggers a specific action.
It triggers the boost rule. This is vital. The standard dose to the bed is 60 gray, but the rules change at that 1 millimeter mark.
Precisely. If that margin is 1 millimeter or less, or if it's frankly positive, or if there's E&E, you boost that specific area up to 66 gray.
So let's play that out. If I have a patient with a 4 millimeter margin,
you treat the bed to 60 grays. You do not boost to 66. A 4 mm margin is considered clean enough for the standard high-risk dose.
So it's technically close from a surgeon's perspective, but from a radiation oncology protocol perspective, it falls into the standard 60 gray bucket.
That's the key distinction. So your defensible board answer is, if the margin is within 1 mm, I treat as highest risk and boost to 66 gray. Do not say less than 5 mm.
You'll be accused of overtreating and causing unnecessary toxicity.
Correct.
Yeah.
Now let's flip the coin. When is it actually safe to just observe a patient? To do nothing?
This has to be rare.
It's very rare. Observation is okay only if all of the following are true. And I mean all of them. Low-grade histology.
Okay.
Early T stage, so T1 or T2. Widely negative margins, here we are talking more than 5 mm.
Yeah.
And absolutely no PNI, LVI, or nodal disease.
You can cite Cho et al. From Annals of Surgical Oncology 2016 for that, but you have to be so careful. If you have a high-grade T1 with beautiful margins, you treat. A low-grade T1 with PNI, you treat.
A very exclusive club, the observation club.
Okay, let's move on to the actual planning. Defining the parotid bed CTV. This is where, a lot of people struggle because the anatomy is complex and, well, it's been surgically altered.
We use what we call the 3-tier approach. But before you draw a single line, there's a prerequisite, a non-negotiable first step.
And what is that?
Preoperative imaging fusion is mandatory.
Okay, why? Why is that so critical? Can I just look at my planning CT?
No, because the surgeon has removed your main landmark. The parotid gland is gone, the tumor is gone, the tissues have all collapsed into that empty space.
You're flying blind.
You're flying blind. You have no idea where the tumor actually was. So you have to fuse the pre-op CT or MRI or PET CT to map the original tumor extent onto your new planning scan.
And RTG 1008 is really explicit about this. Don't trust the post-op anatomy by itself.
Oh.
Okay, so we've done our fusion. Now, let's define those 3 tiers of the clinical target volume, the CTV.
Tier 1 is CTV1. We call this the broad bed.
Okay, what's in the broad bed?
CTV1 is your pre-op GTV, the tumor volume from your fusion, plus a generous 1.5 to 2 centimeter expansion. It should cover the entire surgical bed, the scar. But here's the crucial part. It has to include deep lobe risk.
What do you mean by that?
Even if the surgeon only did a superficial parotidectomy, you have to extend your volume down to the depth of the styloid process.
And why is that?
Because the deep lobe of the parotid sneaks through that little tunnel by the styloid. Recurrences there are a disaster. They're in the peripharyngeal space. They're hard to salvage. You have to cover that potential deep spread. If you don't, you're leaving the back door wide open.
Got it. Okay, tier 2. CTV2.
This is the high-risk bed. It's a tighter volume. It represents the area where the tumor actually was sitting.
So it's the resected tumor bed plus 1 centimeter.
Right. And this volume also specifically includes any named nerve pathway that was involved.
And finally, tier 3. CTV3, the boost volume.
CTV3. It only exists if you have those specific triggers we talked about.
The boost rules!
Right. The close or positive margin or the ENE. If you have those, you create CTV3. And this is just the tumor bed plus 5 millimeters. It's a very focused, high-dose region.
So it's like these concentric rings of risk. You have the broad bed, then the tighter high-risk bed, and then the core boost volume.
It's exactly like a target.
Now, for the boards, you can't just point to a screen. You have to describe the anatomic borders of the parotid bed with your words.
You do. You have to paint a picture. So let's box it in.
Okay, what's the superior border?
The zygomatic arch. That bony bridge of the cheek.
Inferior and medial border.
The styloid process.
Right.
That bony spike is your landmark for the depth and the bottom of the parotid.
Anterior.
The anterior border of the masseter muscle, the big chewing muscle.
And posterior.
The mastoid bone. That hard lump you feel right behind your ear.
That gives you a nice box. But what if you're not dealing with a parotid primary? What if it's a submandibular gland tumor?
Right, those rules don't apply. So you obviously use the pre-op imaging. But if that's not clear, here's a great trick. Look at the contralateral gland.
The one on the other side.
Yes. The anatomy is symmetric. The contralateral submandibular gland shows you exactly where the ipsilateral one used to be. You can use it as your anatomic guide.
That's a great tip. Okay, let's shift gears to a really specific high-stress topic, facial nerve tracking.
The facial nerve. It runs right through the parotid, so it's always at risk.
And the rule is that coverage is not automatic. You don't just include it to be safe.
No, it is not a vibe. It is triggered by very specific signals.
Okay, what are those triggers? When do you have to include the facial nerve pathway in your high-dose volume?
You include it if there's gross involvement on scans or noted by the surgeon, if there was surgical sacrifice of the nerve, like in our case,
Right.
if the patient had clinical dysfunction, like a facial droop, before surgery, if pathology shows P&I of a knee nerve, or, and this is a key one, if the histology is adenoid cystic carcinoma.
So why does ACC get special treatment here, even without other findings?
It's that neurotropic nature again. It just loves nerves. Even without any clinical signs, the biology of ACC just demands that we assume there's microscopic spread along that nerve.
So we have a trigger. How far do we cover the nerve? Where do we stop the field?
We use the stylomascoid foramen concept. For a board-safe answer, RTOG 1008 says standard coverage is up to the skull base, to the stylomascoid foramen. That's the little hole where the facial nerve pops out of the skull.
And what if there's gross involvement? The surgeon says the nerve is just encased in tumor.
Then you have to chase it higher. You have to extend your field along the facial nerve canal right through the petrous temporal bone, heading toward the geniculate ganglion. You're following that road back towards the brainstem.
So board-safe phrasing is key here. You'd say, I will track the facial nerve pathway toward the stylomastoid foramen.
Exactly. Unless there's gross involvement, stopping at the foramen is the standard correct answer.
Perfect. Okay, let's assign some doses to these volumes we just built. The dose level algorithm or the RTOG ladder.
Let's climb the ladder. We'll start at the bottom run, the elective neck. The nose we're treating just in case.
That's 54 gray.
Correct. Now the next rung up, the high-risk bed and any involved lymph nodes.
That's our CTV2. It gets 60 gray.
60 gray. And the top of the ladder, the boost.
66 gray. That's for CTV3. And let's repeat the triggers. Close margin, so 1 millimeter or less, a positive margin, or ENE.
Right. Now, what if the surgeon calls you and says, look, I had to leave a chunk of tumor behind? Gross residual disease.
Then you have to escalate even further. You'd go up to around 70 gray. But, that's pretty rare in these cases. If there's gross disease left, you're asking if maybe they need to go back to the OR first.
It's a different clinical scenario. And the fractionation for all this.
Standard. 2 grade per fraction.
And the timing.
You want to start within 8 weeks of surgery? You don't want to give those microscopic cells too long to wake up and get going?
So let's apply this to our case anchor. We have ENE and a margin less than 1 millimeter.
So we're going all the way up the ladder. CTV3 gets 66 gray. CTV2, the high-risk bed, gets 60 gray. And the elective neck gets 54 gray.
Perfect. Now, speaking of the neck, let's talk about elective neck coverage. This is another area where people can get trapped.
Okay, so node-positive disease is easy. If the patient has positive nodes, you treat the neck.
Right. You treat the involved levels comprehensively, usually 1B through 4. You boost the site of the ENE to 66 gray. That's just standard head and neck principles.
The real trap is the N0 neck. The patient with no suspicious nodes on scans or path. Do we treat it?
It's all risk adapted. It's an if-then situation.
Okay, let's run through the scenarios. What if the patient has high-grade histology or a big T3, T4 tumor?
Then the risk of occult microscopic spread is significant. You should strongly consider treating the ipsilateral neck, levels 2 through 3, and maybe 4.
Okay. What if the primary tumor is in the submandibular or sublingual gland?
Then you absolutely must include level 1B. The lymphatic drainage is direct. You can't skip it.
Now for the controversial one, what if it's adenoid cystic carcinoma and the neck is N0?
This is the one that trips people up constantly. Prophylactic or elective nodal irradiation is not mandatory for ACC.
Really? But it's such an aggressive tumor locally.
It is, but its rate of spreading to lymph nodes is actually pretty low. It's only around 5 to 8%. It prefers to travel along nerves, not lymphatics.
So for a T1 ACC with an N0 neck, you'd leave the neck alone?
Generally, yes. You'd only consider treating the neck for bigger T3, T4 cases, or if there are other really high-risk features. The board-safe answer is nuanced. Don't say you never treat an ACC neck, but don't say you always do.
Okay. And what if it's a low-grade, early-stage tumor of another histology?
Then you generally omit elective neck treatment. The risk is just too low to justify the toxicity of radiating the neck.
We talked about targeting level 2 for parotid cancers. Why is that the hotspot?
There's a meta-analysis by Warshawski from 2020 that gives us the data. It shows that level 2 is by far the most dominant site of spread for parotid cancer, about 16.5%. If it's going anywhere, it's going to level 2 first.
Okay, let's move to toxicity and what you call the parotid sparing paradox. This is a great concept.
It's one of my favorites because it sounds so backward at first. We're always talking about parotid sparing.
Yeah.
But in a parotidectomy case,
The ipsilateral parotid is either the target or it's already sitting in a jar in the pathology lab. It's functionally gone.
it's gone. So all of your sparing efforts have to shift to the other side, to the contralateral parotid and the contralateral submandibular gland.
So what are the quantec constraints we're aiming for on that other side?
To avoid severe permanent dry mouth or xerostomia, you want the mean dose to at least one carotid gland to be less than or equal to 20 gray.
Okay.
Or if you just can't get one that low, you want the mean dose to both glands to be around 25 gray.
And we have good evidence for this, right? The PARSPORT trial.
Exactly. Nothing at all. Lancet Oncology, 2011. That was the trial that proved that IMRT significantly reduces grade 2 or worse xerostomia compared to older techniques. It's why we use IMRT for head and neck.
Now, here's the detail that I think separates a pass from a high pass on the boards. The submandibular gland.
Yes. Everyone forgets about the submandibulars. They obsess over the parotids. But physiologically, the submandibular glands provide about 65% of your unstimulated saliva, your resting saliva.
And that's the saliva that keeps your mouth comfortable when you're not eating. It's what prevents you from waking up at night with your tongue feeling like sandpaper.
Exactly. The parotids are for when you're eating a steak.
Yeah.
But for just baseline quality of life, the submandibular is absolutely critical.
So what's the dose constraint for it?
There's data from Murdoch-Kinch that shows the gland can recover function if the mean dose is kept under 39 gray.
So the practical tip is, if level 1B is not a target, say in an N0 case, you have to make it a priority to keep that contralateral submandibular mean dose less than 39 gray.
That is the parotid sparing paradox in action. You spare the glands on the opposite side to save the patient's quality of life.
Okay, a quick word on chemotherapy. Does our patient, with all his bad features, get concurrent cisplatin?
No,
Yeah.
it's not standard.
Yeah.
This is not like squamous cell carcinoma of the head and neck. We just don't have the high-level evidence for chemo and salivary glands yet.
But there is a trial looking at it, right?
Yes, RTOG 1008, which we've mentioned a few times. It's investigating weekly cisplatin versus postoperative radiation therapy alone. But the results aren't in, and it's not practice-changing yet.
And what about the retrospective data?
There's a big NCDB study from Amity in 2016 that showed no overall survival benefit to adding chemo.
So the bottom line is, do not add chemotherapy outside of a clinical trial.
Correct. Stick to the radiation.
Let's put this all together then. IMRT planning and technique. Walk me through the setup.
It's a pretty standard head and neck setup. The patient is supine in the thermoplastic mask to keep their head still. We use a shoulder pole to get the shoulders down and out of the beam path.
And you recommend IV contrast for the simulation scan.
Yes, it really helps you see the blood vessels and delineate the neck levels much more clearly.
Okay. What are the planning priorities? Number 1.
Coverage. You have to cover the boost volume and the nerve pathway. You cannot compromise on hitting the cancer.
Priority number 2.
Xerostomia sparing. Drive that contralateral parotid mean dose down below 20 to 25 gray. Get that contralateral submandibular mean below 39 gray.
And number 3.
Standard normal tissue constraints. Keep the spinal cord max dose under 45 gray. And really try to minimize any hot spots in the mandible to prevent osteoradionecrosis down the line.
And you mentioned a pitfall earlier, the unrecognized deep lobe.
It's so important, it's worth repeating. Make sure your CTV extends all the way down to the depth of the styloid process, even if it was just a superficial parotidectomy. If you miss that deep lobe, you risk a parapharyngeal recurrence, which is a complete nightmare.
Okay, let's synthesize this. Give me the final plan summary for our case anchor.
The final plan. For our 62-year-old with salivary duct carcinoma, close margins, and ENE, we are using a 3-tier CTV approach. 66 gray boost to the close margin and the ENE site,
60 gray to the rest of the high-risk bed.
and 54 gray to the elective neck levels.
We are tracking the facial nerve path up to the stylomastoid foramen.
We are prioritizing the contralateral parotid and submandibular glands for sparing.
And no concurrent chemotherapy.
Right. And for counseling, you explain the goal is to reduce recurrence risk. It'll take 6 to 7 weeks. The main side effects will be fatigue, a skin reaction like a sunburn, and dry mouth.
And long-term, they need to focus on saliva substitutes, impeccable dental health, and lung surveillance, because salivary duct carcinoma can metastasize to the lungs.
Perfect. Now, before we finish, let's quickly cover the big oral board traps, the things you have to know to avoid failing.
Let's do it. Trap number 1.
The close margin. The trap is calling anything less than 5 millimeters close and boosting all of it.
And the correction is
Only a margin of 1 millimeter or less triggers the 66 gray boost per RTOG 1008.
Okay. Trap number 2.
The N0-ACC neck. The trap is automatically treating the neck for any adenoid cystic carcinoma.
The correction.
Nodal spread in ACC is actually rare, only 5 to 8%. You really should only consider elective neck treatment for T3, T4 cases.
And trap number 3.
Ignoring the submandibular gland.
And the correction is, of course, remembering that sparing the contralateral submandibular is critical for baseline moisture when level 1 is not a target. Don't fry it if you don't have to.
Excellent.
Okay, let's wrap up with some quick board review questions. I'll give you the scenario, you give me the answer and rationale.
That's good.
Question 1. A 55-year-old with a low-grade acinic cell carcinoma. It's 1.8 centimeters. Margins are 4 millimeters negative. The neck is N0. What's your recommendation?
The answer is observation. The rationale is this is the definition of low-risk disease. It's low-grade, small, the margin is greater than 1 millimeter, and there are no adverse features. Radiation is not indicated.
Perfect. Question 2. A 60-year-old with a T2N0 adenoid cystic carcinoma. The margins are 3 millimeters negative, but there is incidental PNI on the pathology report. How do you manage the neck?
Okay, the answer is observation of the neck, but you treat the primary bed. The rationale is you have to treat the bed because of the PNI and the ACC histology. But an N0-ACC that's not T3 or T4 does not require elective neck irradiation.
Right. The risk of nodal failure is low. Okay, last question. High-grade mucoepidermoid carcinoma, an ipsilateral neck dissection was performed. What are your key planning constraints for radiation?
The key constraints are contralateral parotid mean dose less than 20 to 25 gray AND. Contralateral submandibular mean dose less than 39 gray. The rationale is that the ipsilateral glands are gone, so you must save the resting saliva source on the other side.
Fantastic. Let's finish with the top clinical pearls from today, the big take-homes.
Pearl 1. Memorize the ASCO strong recommendation triggers. ACC, high-grade, positive margins, PNI, nodal disease, LVI, and T3, T4 disease.
Pearl 2. The RTOG boost logic. The cutoff for a 66 gray boost is that 1 millimeter margin.
Pearl 3. Pre-op imaging fusion is absolutely mandatory. Don't even think about planning without it.
Pearl 4. The Quantec parotid rules. Mean dose less than 20 to 1 gland, or both less than 25.
Pearl 5. The submandibular recovery threshold is a mean dose of less than 39 gray.
And Pearl 6. Chemo is for clinical trials only.
Right. And looking ahead, our next session, episode 36, is going to be a deep dive entirely on perineural invasion, PNI. We're going to talk about named nerve highways like V2 and V3 and skull base extension. We're really going to map out the nerves.
Awesome. So to summarize today, remember the 3-tier CTV approach, the 60 versus 66 gray dose split, and that all-important parotid sparing paradox.
Complete practice oral boards at radoncelearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.